Good afternoon, everyone. Thank you all for having me. If I'm a little low on my voice, let me know. I tend to move around, so I'm very interactive, and so it's more dynamic than hopefully you guys are used to. Feel free to ask any questions in the meantime. I know we have a Q&A sessions at the very end, but if something just pops out and you're like you have to ask it, don't hesitate. I apologize for some of this. There might be some narcissism in some of these slides, but my research team created some of this. So if you're looking at a third person, you'll see like, why is this guy putting his own picture and stuff on there? So I just saw some of this last night, so I apologize. To give you a little background, so just like Diane said, thank you for the introduction. I'm an emergency medicine physician by trade. Went to medical school in Chicago at Rush Medical College, and then went down to the South at LSU to do emergency medicine in Baton Rouge, and fell in love with the South. And since then, I've called the South my home, and moved to Houston where I got recruited. And since then, it's just been a whirlwind of adventures, I guess, in healthcare. And I'll take you through a little bit about it, and I'll go into how I started with the freestandings, and it'll help you understand where the freestanding emergency centers concept came through, and then microhospital and the evolution of both of these two entities. So who I am, I think Diane told you a little bit about it. We helped start the freestanding industry in Texas about 10-ish, 12 years ago. By that time, we had about 30 plus locations in Texas, Colorado, Rhode Island, and then I started getting really, really good at what I was doing. And so I said, hey, I need to venture out and do more. So I started development. So we started doing medical office buildings, which is easier, just real estate plays. And then started doing ASCs within those medical office buildings. Then started doing JV ventures, and then said, hey, we need to do a little bit more. You know, as our experience grew, we started getting more and more complex. So we started doing microhospitals, general acute care hospitals, started doing consulting work to see exactly how we can evolve this concept. And so we've got locations in Texas, Louisiana, Arizona, some in Colorado, and then I'll tell you about the Rhode Island ones, but we eventually closed those. Not necessarily a very accepting state for freestandings or microhospitals. This is a little bit so these are some of the facilities we own. We own some large general acute care hospitals. So we own like the Heights Hospital in Houston, which is, God, I don't know, probably about 100-bed facility. So large facility, 200,000 square foot, sits on 4 acres. This is the second picture is an office building we're developing. It should be ready in May of this year, which is about 100,000 square foot, structured parking. It'll have 2 ASCs within its premise. Very, you know, we stay within the high-end range of services and developments. And then kind of start off with what your talk is about is freestanding ERs. So the question is, what is really a freestanding ER, right? And why does it really matter? And how does that impact what you guys are doing in terms of what you're learning? And how does that impact in terms of healthcare and where the future of healthcare is going? You know, as an emergency medicine physician, you know, I always thought that the delivery of healthcare was a problem, right? We know in medicine that there has been lack of access, not only on the patient side, but also from the physician side. And the delivery of healthcare, we always thought was in trouble because it was more volume driven. It was not being patient centric. We didn't get time to talk to our patients, explain things. And so we wanted to change things, right? We had this very altruistic mentality on wanting to change healthcare. And that's where this came about, right? So how do we take emergency medicine, which is usually the front doors to the hospitals, and bring it to the masses, right? And this is where the freestandings came out, right? If you take the emergency department out of the hospital setting and move it into a community setting, you're decentralizing its access, right? So you're decentralizing healthcare. You're bringing in your front door emergency room to now the periphery of the community, either in the suburbs or in the rural communities or where have you, but not in a large metropolitan area. And so it was there. It spawned from the need where ER services and hospitals were overcrowded. Their ER wait times were 4 hours, 5 hours, 6 hours, 8 hours. They were holding patients. They were holding beds for people to be admitted on the inpatient side, and And it also is spawned from the fact that ER physicians wanted to have a little bit more control over their specialty in terms of how they wanted to take care of their patients. And so similar to what the surgeons did with the ASC model, and so we did this with the freestanding model. We talked about the decentralization. So part of what the freestanding does is that it doesn't have everything that a typical or full-blown hospital ED might have, right? It sees lower acuity patients, right? If you look at the ASI levels, right, you're seeing level 3, level 4 patients and not necessarily the higher acuity level 5 patients, right? You're not seeing the STEMIs, you're not seeing the stroke patients as much, you're not seeing the trauma patients, right? Most trauma patients are bypassing these freestandings and going straight to the hospital setting. So you're not seeing those higher acuity, but there's advantages to that as well as disadvantages to that. It becomes more patient-centric, and as I said before, there's no inpatient beds, there's no surgery with freestandings. A lot of these freestandings, depending on if you break down the model, you have different affiliations. So either you have hospital-affiliated freestandings and you have independent freestanding centers. And the hospital affiliations are running through the tax ID number and the hospital license of the hospital versus the independents, which have their own licensing requirements. And these licensing requirements are state-specific. So some states are specific in terms of what they want, how they want to run, and versus some states that don't even have the legislative license on their books. So if you look at the freestandings and you say, hey, how prevalent are they? They're prevalent in a majority of the US, but in different forms, right? The green was where I focused on, is because that's where I'm from, it's an unrestricted state. So that means that you can put freestandings in any part or any neck of the state without having any issues. There is a legislative process that was enacted that gave freestandings its own voice and its own license in the State Department of Health code. And because of that, now, while applying for a hospital license, you could also apply for a freestanding license, similar to what happened in Colorado. So Colorado took the exact legislation that Texas passed and copied this legislation on its books, and so now allowing that state to have its own licensing and regulatory standards similar to what Texas is. The other states, mainly in blue, if you see, are hospital affiliated. What that means is that they're owned or operated by a hospital, where the majority ownership is usually with that of the hospital. And that way they're using the hospital contracts, they're using the hospital CMS, they're using all of the hospital services that comes along with it. And those facilities are acted or treated as feeder sources to the main hospital. And so now you're using a hub and spoke type model where a hospital system may put in a freestanding on the periphery of a town or location, and that will act as a feeder source into its hospital system. And it helps decompress some of the current wait times that they have in their ERs because of the overcrowding issues, the busyness of their ERs. So regulation-wise, we talked about state having legislative control of what a freestanding or the definition of a freestanding. And so not all states have legislation for freestanding emergency centers, meaning you're not going to be recognized by the state or the State Department of Health in terms of licensing. Either you're a hospital, you're an ASC, you're a dialysis center, you're an urgent care, but they don't have a classification as to where the freestanding falls. Different states vary, and you may have a freestanding under a subclassification of either a hospital or an ASC because it provides emergency services. And so every state is quite unique in that sense. There are different architectural standards, state by state, but normally all of them mimic, an ASC and hospital. It's a meld between the two on the architectural standards and the life safety Department of Health standards and code. What that does allow is that it allows for lower construction costs. Right? You're not having to build a large hospital system. Right? You're not having to build a 200, 300, 400 bed hospital. Right? It is just a simple department. Most of these freestanding ERs are usually between 8 to 12 beds, or maybe 8 to 15 beds. And so your cost of construction is decreased significantly. You don't have all of the other requirements for it. You don't have all of the imaging requirements, the lab requirements, or the pharmacy regulations. On the federal side, CMS does not recognize freestandings when it's independently licensed. Now, if you're part of a hospital system and it's either an HOPD or it's an affiliate of the hospital, then you follow the hospital guidelines, and the CMS doesn't recognize it as independent, but as part of the hospital. But if you're licensed independently as a freestanding, CMS does not recognize any of those facilities. And because of that, there is no avenue, there's no mechanism to get deemed status or get CMS for a Medicare or Medicaid license. So those are some of the hurdles or challenges. We, in 2010, applied for CMS. We asked CMS to give us a special consideration to allow to become a CMS certified provider. And at that point, they had refused, saying that they didn't have a classification or a category to put us in. And so they said that maybe in the next 5 years to come back to them. I'm not necessarily sure there has changed anything since then, but at this point, there's still no recognition by CMS for these facilities if you are independent. If you're hospital-based or if you're under the auspice of a hospital, then you'll be recognized, but you're using the hospital CMS license, you're using the hospital state license as well as the medium in which they're recognizing you. On the insurance side, there's definitely regulations as well. Not every state has the same insurance regulations and legislation to support these facilities. Hospitals have a considerable amount of support and pull with the Hospital Association, but not necessarily that of the freestandings. And because of that, it's a difficult market on the insurance side, because not all insurances recognize freestanding, depending on the state. Not all insurances will recognize it, and that means that the reimbursement level may not be as high as a hospital or an ASC, and that's going to lead to margin compression, and we'll talk a little bit about that. But what it does do in some states, because it has legislation and it has its own license and recognized by that state, these facilities are able to charge facilities fees, right? Similar to what ASCs and hospitals do. And that's what created a storm of construction and building in the freestanding industry in Texas, spread like wildfire because of the fact that they're able to charge these fees in addition to the professional side, and those fees are at a much higher rate, and yet their operational overhead was such lower, so their margins were a lot higher. And so your break-even point for these facilities were very low patient volumes. And because of that, people saw this as an advantage and capitalized it. And that's where the free markets come into play. But then that also goes to some of the disadvantages. We'll talk about that, because that spawns the barrier of entry to this industry is very, very low, and that means that everyone can get into it. It's not that difficult to get into this space. So, advantages for the freestandings are that its location. Where majority of the hospital systems we think of as a centralized system, right? Where this is more of a decentralized, where location is retail oriented, right? A lot of these freestandings have retail in mind, right? They're looking at the DaVita type model, where it's in a strip center, it's in a small community strip center, or it may be a freestanding building, but it's a small footprint. Accessibility is the key to part of their success, right? If you can get a facility into an area where the demographics is feasible, the payer mix is feasible, and an area where there's a need, where the volumes are high or the ER volumes are excessively high, then they may benefit from this. Part of this is their advantages, end user experience, right? What differentiates freestandings from the hospital ED environment is the fact that they have no wait times. They have very little wait times, right? You're not having to wait through hours and hours of patient volumes that are inundating the larger hospital systems because they have traumas, they have bed holes, they have psychiatric holes, they have a lot of other issues that are plaguing the systems. And what these facilities are doing is they're decompressing those ERs, and because of that, they're seeing the lower acuity volumes. They're not having those wait times that the larger hospital systems typically experience. They have customer service in mind, meaning very, very patient-centric oriented. When I talk about retail, if you look at the retail markets, right? Retail market is customer service driven, right? If you take customer service and say, we're going to take care of patients to the best of our abilities and treat the patient as a true customer, that is what a freestanding embodies. And that's why when they're marketing their locations, it's also very retail driven. You have much better patient and employee satisfaction. If you look at if you look at any Press A&E or patient satisfaction scores, you'll see that it far exceeds that of any traditional hospital system. And part of that is because of the fact that they have lower wait times, but they also have lower acuity, meaning they have the time, they have the ability to be able to spend with the patients, they have the time to actually talk to them, explain to them, do the things that they need to do. And give them the attention that they're requesting. Some of these are also looking at efficiencies, right? They're popping up all over the place because of the fact that they have lower capex, right? It doesn't cost much to build these things, right? It's only costing $3 to $5 million per location, and that's outside of a freestanding building, right? If you're building it in a strip center, and typical size roughly can range from 5,000 to 10,000 square foot. The build out for this is very nominal, right? You're not having to build everything out. There's no inpatient services, there's no surgery, there's no ICU, lab is minimal, radiology is minimal, ultrasound is minimal, and your staffing is minimal, right? So you've got a moderately complex type of CLIA lab. You've got minimal radiology, you've only got CT and X-ray, very little have MRIs in them, just because utilization of MRIs is not necessarily quite there. And there's very little indications on the ER side to see if the MRIs can be used or not. And like I said, minimal pharmacy requirements. You don't have to have a full-time pharmacist on staff. You can have consultant pharmacists. You have just the regulatory side on the Department of Pharmacy, where the State Board of Pharmacy will ask to do so many regulatory checks and compliance for that facility. Some of the disadvantage, right? So you look and say, hey, the freestandings is the way to go, and we should have one in every state, and we should have one in every corner. The problem is in Texas is that you kind of have that, right? You have one at every corner. If you look at the CVS, you look at the Walgreens, right? And they're on opposing corners, right? Well, the same thing happened to the freestanding market because the barrier of entry was so low that everyone wanted to get into it, right? Like ASCs, right? When the ASC market, 20 years ago started, everyone started getting into it, right? Reimbursement levels were really, really high, then everything just started dropping, right? You had margin compression, reimbursement rates started dropping, and yet they had built, and so you had a decline. Same thing with the imaging centers, right? Imaging centers were highly popular and highly prevalent, and you saw them just going on the decline. Very similar to this, right? When we started this, industry, 12 years ago, there wasn't anything, right? It was, what Diane and I were talking about, it was the wild, wild west. You can build something, and the state, the state would accept it, right? The first center that I built, there was no legislative code. There was no Department of Health standards, right? So I went to the Department of Health and said, hey, I'm going to build this. Would you accept this? And I mishmashed hospital code and ASC code together, and I said, would you accept it? And they said yes. So it's the only facility that was grandfathered, and today it probably meets very little. So we tore it down and built a new one on its spot. But at that time, there was nothing out there to govern what that looked like, right? So we talked about some of the advantages, right? But some of the barriers of this is, and I said, some of you may look at it as a positive or negative, but CMS acceptance is, in my eyes, a barrier, because you're leaving out a huge population of people that cannot access or utilize that facility, right? So right now at our facilities, if a person with CMS walks in, we take care of those patients for free. So we write those off, right? We legally can't send out a claim to CMS, to Medicare, right? And we don't balance bill on those, so they don't get a bill at all for that. Barriers is legislation. Some states have legislation that allows the acceptance of freestandings, while some states don't. And so we have to be cognizant of the states that have this, the states that have certificate of need that allows for something like this to be built versus the ones that do. Low cost of CapEx, I use that as a barrier, and you're like, no, that shouldn't be a barrier. But the problem is that because of the low cost of building, everyone can get into it, right? So you can put one up tomorrow, and 6 months from now, you can find another one across the street, and it's not stopping the competition, right? So competition is good for business because it drives patient care, right? So part of what I've said in the past is competition to me is the byproduct of it benefits the public, right? If someone comes into an area where it has adequate or mediocre service or coverage or care, and a new competitor comes into the market and it elevates that level of service, the level of care, then what the other hospitals or the other facilities in the area have to do is they have to come up, and your benchmark or your threshold raises, right? So your level, your bar is set higher than what you normally would have, and so the byproduct of what you see in the community is that better patient access and better patient care. Do I think that it bodes to better public health? I think only the future will hold and tell us if it does or not, right? As this industry plays out. But some of the disadvantages, it's not equipped for everything, right? It's not a trauma center, right? Can we handle all of it? Sure we can. Are there all ER physicians in these facilities? Probably about 90% of them. We've got, in our facilities alone, we have some family practice physicians that have done ER fellowships and have only been working in the emergency rooms, and so we allow them to work at our facilities. But they're not taking the gunshot wounds, they're not taking the stabbing victims, they're not seeing the high acuity MVAs that the EMS is bringing in, because they're being bypassed to go to a trauma center because they're designated trauma centers. And so your EMS transports have policies in place that prevent some states from accepting traumas. And so they're already being bypassed by EMS protocols alone, because it has to go to a designated trauma center. It has to be at least a level 2 or level 3, and then even to some extent, depending on the extent or the severity of the injuries, then it has to go to a level 1. It doesn't have any inpatient beds, doesn't have any ICUs, doesn't have any of these additional things that a normal hospital would have. Like we talked about, X-ray and CT are usually the mainstay, because that's in the legislative code, that's in what the Department of Health minimum guidelines are, and the MRI is far and few between. Your lab is usually moderately complex, so there's a lot of things that end up getting sent out, right? So you have blood cultures, you have the high complexity testing, the immunology assays, all of those get sent out to a send-out lab or a reference lab, or even to the hospital. And so if you give you an example, if you have a pediatric patient that came in with a fever and someone does an LP on them and you're looking for that, well, that LP, those results aren't actually done at these freestanding centers, and so they're being sent out to the hospitals where they actually have a technician that's actually doing the counts, and then those results are being faxed back to the facility. So there's limitations on what they have. What are some of the other things in terms of disadvantage is confusion, right? End user confusion. When I talk about the end user, I talk about the patient, right? The patient or the consumer. I use patient and consumer interchangeably here. And part of the perception and consumer education is what a freestanding can and can't handle, right? since the severity index that they're seeing is usually level 3s and level 4s, and then on the level 5s, you're still seeing them, but then eventually those level 5s get sent out or transferred to a hospital setting. So on the public side or the consumer side, there's a lot of misconceptions, and because they feel like the freestanding, because it's a new concept, is that it's a glorified urgent care or clinic. And so, and because they don't understand what that is, when they get the bill, they're gonna be shocked, right? There's going to be some sticker shock. They're gonna see, well, I've got a physician professional charge, and then I'm also gonna see a technical component on the facility charge, and they're like, why is that happening when I don't get charged this on the urgent care models? It's a lot different, because of the fact that it's got legislative support and it's got a license behind it. It's all able to charge those, but it leads to consumer confidence issues. And then it becomes expensive, right? It's an out-of-network. Majority of these independent freestanding ERs are out-of-network. It doesn't make sense to go on an in-network model because the reimbursement's a lot lower on the in-network side. Now, the facilities that are part of the hospital, so if they're a hospital affiliation, hospital HOPD, those will then carry the hospital contracts. And so most of them at that point will be in-network. But if there's an independent operator, independent facility, most of these to date right now on the out-of-network market, and that's eventually changing. If you look at some of the backlashes of freestandings is because of its high cost of healthcare. The bills are high, and you see this huge backlash on social media as well as in the in regular media. You see it on the newspapers and the TV exposés where they talk about how freestandings are extremely expensive and driving up the cost of healthcare. And so all of those negative perceptions impact consumer confidence and the ability for them to eventually use that facility. Part of that is the revenue side, right? We talked about being on an out-of-network model mainly, meaning that it's challenging to get the reimbursements, right? As an in-network, if you're contracted with some of the larger payers, well then it's a lot easier you're sending a claim out, they're sending you back a check in record time, right? When you're out-of-network, every check, every dollar is a fight. It's hard. You have to appeal it. You have to fight for all of those things, because nowadays, unlike 10 years ago, the insurance companies are getting wiser, and they're getting wiser to what the freestandings are and how they're charging patients and the insurance companies themselves, right? The facility fees back when it was created, right, was a way for hospitals to manage the operational overhead of that hospital, right? They never envisioned a small freestanding ER to come in and charge the same as that of a larger hospital, because the operational overhead is significantly lower, right? They never anticipated this industry. And because of that, now they're reacting to it and saying, okay, we see that we designed this for the hospitals so that they can keep their lights on, keep the doors open for the community and the public. But now the freestandings are coming in and finding these loopholes, and they say, hey, look, we're gonna build really, really low, and our OpEx is really low because our staffing requirements are low. Our operational requirements are really low. And so now we're going to be able to capitalize on this facility fee, which the hospitals have very little margins, right? Sure, insurance companies are coming back and saying, well, we're changing that. So, right, this is, and I've said this probably about 4 years ago, and I said, the industry's not going to die, but what's going to happen is that you're going to have margin compression. And part of that is going to be the stroke of a pen, not legislatively, but by the insurance company CEO. Right? They're going to say, I'm going to pay you this much, and here's why. And there's going to be no recourse with this industry. And unlike which a hospital has a support with the hospital association as well as payer contracts and what have you. But you're seeing that year over year, right? I keep a tally of what my margins used to be starting 10 years ago to what they are now. The golden years, I call it, right, of reimbursement in this industry, and it started off fairly high, and then every year there has been margin compression, year over year, and it's going to continue to get lower and lower until it stabilizes to what the insurance companies will deem is appropriate for this industry. So I'm going to jump into micro hospitals a little bit, right? And to because the micro hospital is just an extension of a freestanding, right? It is an evolution of a freestanding. And so you're like, well, why even do a micro hospital when you can just do a freestanding? Because it's got lower costs. It's a smaller place. You don't have to hire as many people. I don't have to have all of the bells and whistle. But you can't get into certain states with a freestanding, right? There's only some states you can get into a freestanding. There's only some markets you can get into a freestanding, right? So what about all these other states that we highlighted that were outside of the green, right? Well, that has to be a hospital, right? Most states, majority of the states in the U.S. only have licensing for hospitals and not a freestanding. And because of that, the way to get into these markets is using a hospital license. The micro-hospital concept is an architectural concept. It is a term coined by the architects to showcase a small footprint in the hospital industry, period, right? It is a facility that is roughly between 15,000 square foot to 50,000 square foot. Most are within that range. They abide by minimum federal and state hospital requirements, right? Every state has a licensing requirement for what determines a hospital. It could be surgical, it could be OB, it could be ER, it could be inpatient, it could be ICU, all of those things. They have a laundry list of all of these regulations. And the micro hospitals get into a market by using the minimum state and federal requirements. It's a smaller hospital footprint, it's a lot more efficient, and it's tailored to the community. And it's mainly coined as community-based hospitals or neighborhood hospitals. The current market right now, or the current industry in micro hospitals, because right now there's only a few operators that have the majority of micro hospitals in this country. And majority of them started off in the freestanding world, right? Because they started off when they're my colleagues, right? These are all competitors that we all played with, 10 years ago. And majority of them are still ER focused, ER volume, ER traffic, ER driven, right? They're not using the inpatient side. So they may build an inpatient unit. They may build 10 beds, 12 bed inpatient unit, but it stays dark. So they're not utilizing. You're utilizing the beds as a means to acquire the state hospital licensing side. So that's why I talk about inconsistent use of inpatient beds. So majority of them right now don't use the inpatient beds, and because of that, they stay dark. Micro hospitals, similar to freestandings, have multiple affiliations, right? Either you could be independent or you could be part of a hospital system, right? They're affiliations. So you can still do a hub and spoke on a micro hospital, which has a little bit more beefy services than a freestanding if you're affiliated with the hospital and then use their CMS number as well as the hospital contracts. Or you can have the independents, and the independents still abide by the state requirements and the state licensing for that. Location-wise, micro hospitals are located in about 15 plus states, but they're rarely in certificate of need states. Certificate of need is a huge barrier to any hospitals, regardless if it's a micro hospital, freestanding, or anything else. But a lot of states are actually moving away from the certificate of need legislation, right? And so you're seeing more and more legislation being introduced to circumvent certificate of need because it bodes competition, it bodes higher patient care, better service, and I think the legislators are seeing this, as well as a lot of the people in healthcare are noticing that. You'll see, this should have been more colors, but the gray is proposed locations that are CON states that people are trying to get into right now. And we'll see, the only time will tell depending on if they get into these states or not. I will tell you, we went into Rhode Island, which was a certificate of need state, and the hurdles are tremendous, right? You have to go through the legislative process. You have to go through their General Assembly. You have to go through a ton of legal hurdles, and it becomes extremely cost prohibitive to go into those different states. but it's doable. Like I said, if you put your mind to it, it's definitely doable. A lot of what you see in blue are joint ventures, meaning that they have the ability to go into these states, but they're using the branding, the name, the licensing of the parent hospitals. So they may go into a health system in Nevada and then use that health system name and then run a micro hospital as a hub and spoke type model. Go ahead.
Is there anything but happenstance to explain that geographic division between, say, north and south, or the northeast?
So the south, good question. So the south is a lot more open to. So we have less certificate of need, and they're open to more of these ideas. The Midwest and Northeast have been very predominantly historically inaccessible to new facilities. And the insurance companies also back them up, because part of their certificate of need criteria is acceptance or approval from not only the surrounding hospital, but also from the carriers. And so the carriers also prohibited that. So that's why I've never, I did medical school in Chicago, right? And people ask me, like, would I ever go back to Chicago, right, to practice? And I said never, right? For a variety of reasons, right? But part of that is it's not receptive to business, to entrepreneurs, to like myself. It's very prohibitive on new competitors coming into a market, regardless if they're wanting to make change, regardless if they're wanting to improve healthcare, right? Because you've got the status quo, you've got the systems that are already in place that will fight tooth and nail to make sure that their fiefdom is protected. And like I said, unless you're a large system going in, it's very difficult, right? Difficult, like small operators like myself, right? I still consider myself small operator, right? Even though at one point we have, 3,000 employees, I had about 250 physicians on staff at the very peak, and even then it becomes still cost prohibitive for me to fight, this battle, because the hospital systems, let's say if I go back to Illinois, right, try to put that system in and fight with, put a micro hospital. The other hospitals, they're just gonna, fight me in the legal side of it for years, right? So they'll just keep racking up legal costs year over year, and then it'll just stay in limbo for a long period of time. And at what point did they say, hey, you got to stop, and the stock prices have dropped so much that you just got to sell it, right? And you got to get out as much, before you take in additional losses. So the South has been a little more open and receptive to change, new industries, different types of healthcare. And that's where we see the freestandings and the micro hospitals. I think there's value in that, but I think there has to be some changes to it, on the reimbursement side, the way they do their billing practices. But it opens up healthcare to people that normally may have not gotten access to it, right? So I think there's value in some of it. It's just a question of where do we put these facilities, and how do we position them such that the community does have access to these, because it could be really beneficial, and it can be beneficial not only on the community side, but also on the rural healthcare side, because the cost to build these facilities are a lot lower than that of a traditional hospital. So if you look at part of, where this kind of falls into, and this may not be complete, but this is my version of it, right? So you've got your primary care doctors, you've got your urgent cares at the base, right? And then that eventually, if they need additional services, they're going to like these outpatient surgery centers, ambulatory surgery centers. They're going to now a freestanding, which provides ER services and ER care for the sprains, the strains, they're having their pneumonias, things like that don't necessarily need inpatient stay and full hospital services. And now it's becoming more in the community. So the freestanding, the ASCs are becoming more community-oriented, community-driven. And then you've got the micro hospitals that can take a little bit more care of some of their services. And then yet they don't always have everything, and that's when you're going to the full-service hospitals, which are maybe tertiary care centers or specialized hospitals with additional specialties that the micro hospital may not employ or may not provide. To give you an example, so I've got I started off as a micro hospital in Louisiana, in Lake Charles. And what we learned was we didn't provide surgical services in the very beginning. So it was an expensive build. It's still cheaper than a hospital system, right? It cost us $25 million to build. And so much cheaper than a larger hospital. But we didn't have surgery in it. And what we found was that the physicians in the community still needed services, and that was part of the services, right? So we had patients that we were admitting to the inpatient side that were needing surgical services, that needed their gallbladders, their appendix, their what have you taken out, and we couldn't provide for those patients. And so we had to transfer those patients out. And so the community physicians were like requested to say, hey, we need to add these services to the hospital. And so we said, okay, fine. So we're starting. So the facility's only been open less than a year now in Louisiana, and we're starting phase 2, which is now an additional 60,000 square foot expansion, which will have surgery, ICU, cath, endoscopy, all of those different things. It'll have space for physician services as well. So we're progressively evolving to a more full service hospital, even though I started off wanting to just start with the micro hospital. The community will drive, and the community and that market will drive what that micro hospital becomes or evolves into, right? Because as the community needs expand and the community physicians request certain things, you'll see that utilization grows, and you're going to add different service line, right? So we've already started planning for oncology. In 2 years, we'll add. We were asked to add women's services, which I was completely adamant against putting women's services because it becomes a predominantly a Medicaid-driven business, and it has to be very high volume, right? So if I was going to do women's services, we were going to do, a NICU. That means I have to put a level 2 NICU at least in, right? It just kind of dominoes into what you have to put in. You're like, hey, this is not a micro hospital anymore. Like we got to, at some point, things get out of hand, and you got to stop, because if not, you can just keep adding Lego blocks to your micro hospital with expansion. And I talk about some of the disadvantages, and you'll see that later on. So advantages on the micro hospital is definitely location, right? So you're getting into a market that definitely has an area that's a need, but you're able to get into a footprint that's smaller, and because of that, you're able to nestle yourself within the community, which makes it advantageous because now the community can access it. Your customers or your patients are able to get to that fairly easily and not have to go to a large medical institution or medical center. You're able to serve you're able to put these in underserved areas, and similar to a freestanding, we talk about the end user experience, right? And the end user experience is extremely important, right? Customer service is paramount in some of the things that the micro hospital does. So that means that you have to have very little wait times, right? People want to get in and get out, right? This is a very, in this day and age, people don't like waiting for services. They don't want to wait to have X number of things done. They don't want to, even when you're seeing a primary care physician, right? When your appointment's for 10 o'clock in the morning, they want to be seen within the 15 minutes of that appointment, and not have to wait an hour, irrespective of the physician being busy or not, and their schedule is completely booked, and then they're inundated. They want to get in and out, right? They have busy lives, and they expect their healthcare facilities to be the same way. When they go into the emergency room, when they go into a hospital, when they go in for the outpatient services, they want it. It is a service that you have to provide right then and there, and they're not willing to wait for these services. Now the larger hospital systems, tertiary care systems, where they have very specialized services, very specialized care, they're willing to wait for those the rare specialists that's only available, within a 75-mile radius. But for the majority of part, for the bread and butter of what we do, is they want those services right then and there. Some of these advantages include the efficiencies in what a micro hospital does, right? We talked about the low capex, right? That facility cost us only, in the mid-20s to build. The expansion is going to be another 25 to 30 million, depending on the equipment that we use, right? So now it's turned into a $50+ million budget, right, for all in. And you're like, hey, this is not a micro hospital, right? How is that? How is that a micro? And it really it doesn't. But the initial micro we talked about being 15,000 square foot to 50,000 square foot, you can easily build that between 12 and 15 million, right? Depending on what additional services that you add onto it. You have less lab requirements on the micro hospital because since some of these facilities don't have surgical components to it, so that means that they're not doing blood banking, right? They're not needing to keep blood in their hospitals. And then same thing we talked about, no surgery in some of them, and that's state specific. So each state, based on their Department of Health rules and regulations, will determine if a hospital definition requires surgery or non-surgery, right? Or some that may require women's services, or some that may require whatever additional services in order to define that facility as a hospital. So the disadvantages on the micro hospital is you've got states that have definitely certificate of need, and those are barriers of entry into those states. As time passes, I think you'll see these regulations being lifted. You'll see certificate of need being less and less as more states move away from the certificate of need, and you'll see this concept moving into more of a rural setting and a critical access setting where access may not necessarily be available, and because of its smaller footprint, because of its lower expense, you'll be able to see them pop up a lot more frequently, a lot more easily. The only thing that's going to be hurdles thereafter is going to be CMS regulations, right? Because part of the issues nowadays is going to be what CMS deems to be a hospital, right? CMS has its own definition of what deems to be a hospital, and that means primary engagement, right? You have to be primarily engaged in inpatient services in order to be a micro-hospital in the eyes of CMS. And as CMS continues to crack down on this, you'll see those barrier entries being stifled. Even though certificate of need may be going down, you'll see CMS regulations increasing to prevent some of this. In the last less than 10 years, you've seen over 100, rural access, critical access hospitals closing just since 2005 because of the fact that they can't keep their doors open because trying to maintain CMS guidelines, trying to maintain the 2 midnight rule. They just don't have that. In the last year alone, you've had multiple hospitals closing in Louisiana, Texas, Indiana, Kansas. And you go through Becker's and you'll see an article of a hospital closing. And that's because of CMS's. When CMS last year came out with their memo saying that to be compliant with their 2 midnight rule, they're very strict on that, even with the accrediting agencies. So the accrediting agencies won't even look at you if you don't meet these guidelines. So you'll see CMS playing a huge part in terms of the ability of this industry flourishing throughout the country. And then again, the barriers to entry is state-wise, right? The state has to have the ability, these minimum requirements, in order for this industry to survive. And if it doesn't have those the legislation in place, it's going to be hard for this to do well. The micro-hospitals, they're not also equipped to do everything either, right? They're not main trauma centers, but they're larger than the freestandings, and they're able to do more, but still less than that of a main hospital systems. So like I said, most lack surgical suites or ICU. So even though we will evolve into surgery, endoscopy, ICU, and all of those things, and even ultimately women's services, traditionally the micro-hospitals don't have these services. You're not going to see them in them because they're primarily using them as a feeder source, if you're hospital-based, as a feeder source to the main hospital. So the hospital is not going to cannibalize what their current infrastructure is, right? So they're using as the hub and spoke in order to send patients to the main hospital systems. If you're an independent operator, then you're trying to capitalize on the ability to collect facility fees, and so you're just doing ER services and maybe minimal inpatient services and trying to keep your costs down as much as possible to maximize your revenue. Same thing with, similar to a freestanding, you also have end user confusion, right? You also have consumer patient confusion, right? Part of that is they see a smaller footprint facility, meaning even though 50,000 square foot may not be too small, it still may be just a glorified urgent care. It may just be a clinic of some sort or a multi-specialty clinic of some sort. And also part of that is it could be expensive, out of network. A lot of these independent operators that when they first open up a facility is out of network, usually for the first year, and part of that is a payer contract issue, right? It takes usually about a year or so to get into contracting with some of the major payers. And so for that first year, you're looking at out of network billing, and that becomes, that can leave a sour taste in the consumer or the patient. Just because of the fact that when they see this, they're going to say, they're going to feel like they're going to get balance billed thousands of dollars, when on an in-network facility or hospital, they may only have to pay whatever their deductible is, their in-network deductible, whatever, 1,000, 2,000, We're seeing less and less of this is because now you're seeing a lot of the insurance plans are moving to high deductible plans. So regardless if you're in-network or out-of-network, your plans are still high deductible, $5,000, $10,000 deductibles. And so there's a little bit of protectionism there, but still there's still a consumer confidence issue with this facility, and it's new. They don't know if the facility can handle it. They don't know if they can if the physicians that are recruited at this facility are top physicians. They don't know if the staffing is top staff, right? They don't know if the laboratory services are able to do everything. The imaging capabilities are everything, right? So all of this adds to the education of the consumer or their patient, and that just means driving up marketing costs to be able to educate these patients so that they have knowledge of what goes on in these places. The revenue we talked about being difficult to get in the very beginning. So contracts are harder to get in the first year. So it's in some states don't accept new providers, and so if that's the case, then you're not even gonna be able to get in network in some areas, in some markets. Higher OpEx than freestanding is usually it's usually about twice that, 2 to 2.5 times that of a normal freestanding is the operational overhead of a micro hospital. A lot lower than a larger hospital system, but still a lot higher than a freestanding. So you have margin compression just off the bat from the operational overhead that goes into place for a micro hospital, because your staffing requirements are that of a hospital, right? You have to staff for inpatient side, you have to staff for all of the ancillary services, versus on the freestanding, you're not having to have these additional staffing requirements. And so you'll see on the freestanding side, you'll see a lot of cross-trained staff, right? You'll have nurses that run the lab. You have radiology techs that run the lab, or we have paramedics that do certain different things, right? So you'll see a lot of cross-training on the freestanding side, but on the micro hospital side, depending on the state and depending on their rules and regulations, their staffing requirements that has to be met to qualify as a hospital. So regulatory-wise on the micro hospitals is you have state issues as well. So you've got architectural standards, higher construction costs, staffing requirements we just talked about. On the federal side, CMS is the biggest hurdle, right? CMS regulation is primarily, so the primary engagement rule plays an important role and factor into the success of a facility, right? Majority of the facilities or micro hospitals that are currently open right now do not take CMS. They don't see Medicare patients unless they have an affiliation with the hospital where they're using their CMS license under. And in order, my view is a little differently. I think without CMS, you're leaving a huge population, basically to the wayside. And that doesn't necessarily, as a physician, you want to, we went into this industry, wanting to help people, wanting to take care of patients, wanting to provide care to a large number of people, and not being able to take CMS is I think goes against that. Like I said, the deemed status is going to be an issue because of the primary engagement rule as well as the 2 midnight rule. The insurance is also regulatory on the out-of-network model. Insurance payments, are being sent to patients, right? Unlike in-network contracts. And what I mean is that actually when a hospital sends out a bill and the insurance companies, okay, when a hospital sends out a bill and the reimbursement goes out to the hospital, instead of sending to the hospital, it goes to actually the patient on, some of these states. And that's actually in the policies of these insurance companies, Blue Cross Blue Shield being one of them, notorious for that. So then the hospital then has to go after the patient to actually provide those payments. And it's a way for the insurance companies as leverage to make hospitals go in-network at lower rates. So you see increasing claims denial, increasing requests for medical records, kind of makes the revenue go down a little bit. So this is our facility in Louisiana. We won the design award for 2017 or 2018, I forget. So I always tell my architects I said, you have to win a design award for every facility. The color at the top actually changes it's more of a marketing, so it's an awareness month. So every month there is a awareness month, right? So colon cancer awareness, breast cancer, and that changes. And so our marketing and social media reflects that. So it says, please go get your colonoscopy, go get your mammogram, go check, have your women's services done. So, we cater to, like I said, for us, it's how are we different than any other hospital, very patient-centric, very physician-centric. I maintain independence on the physician side. We have, I don't do an employed model at our facilities. I want to try to keep physicians as independent as possible, but we find clever ways to do reimbursement models with them. Some of the challenges, you'll see that we have, not just us, but we have other facilities other companies that are having the same issues. Staffing wise is how do you staff it appropriately? How do you build a culture, such that the patient is first, right, or the physician is first? How do you put in an EMR system that is going to be conducive to a small footprint environment like this, right? And you would not think that an EMR system would be a challenge, but it is. We try to get Epic and Cerner into these facilities, and they flat out refused. And I offered Epic $1 million for the implementation, and they said no. And I'm like, why would you say no? And they said that because of our size, it's operationally it wouldn't be cost effective for them to actually even go it, right? Even me giving them to the implementation dollars to do it, they flat out refused. Same thing with Cerner. So we have challenges. Right now we're building our own EMR system. We partnered with a company out of Malaysia to develop a model for hospitals that are less than 100 beds, because there's nothing out there to cater to that. And so we should be able to, we'll be launching that by the end of this year. Harder accreditation legislation, right? The 2 midnight rule is definitely an issue. Insurance carrier contracts are always going to be a hurdle and a stumbling block with uncertainty in collections. The first year when we went to Louisiana, we had no clue what we were going to get, and we had enough of a line of credit to be able to say, hey, let's try this, right? But there's a lot of uncertainties, especially going to different states. And then expansion, is these growths can get out of hand, right? We're adding this section, this phase 2, phase 3, and then ultimately you lose the entire micro-hospital definition, and you're just a general acute care hospital, and now you're just a behemoth that you weren't trying to become, but it is the evolution, because your communities and the people are going to drive what that looks like. Let's see. Part of this is risky, right? We talked about, hospital closures. There's 120 hospitals that closed since 2005. Microhospitals closure in Indiana, Kansas, as well as Texas in the last year alone, right? You can pull up articles right now. There's a few that just closed a couple of months ago in Indianapolis and Kansas, which was sent kind of shockwaves. And what that does on the real estate investment side is it makes it really hard to get capital, right? So if you look at on the financial world, right, if you look at capital market, right, there's about $1 trillion in capital that is yet to be deployed, right? And there's a lot of it that wants to be deployed on the healthcare side. But unless you have confidence on the real estate investor side or the investment banking side to be able to say, this is an industry that is going to support itself going forward, they're not going to put in the millions of dollars to be able to build these projects, right? And that's where some of the real estate investment challenges come into play, is that the capital markets still don't have a strong consumer confidence in that industry to be able to say, here's 20 million, here's 30 million, here's 100 million, go deploy 3 or these, 5 of these, or 10 of these. So that's about it. Thank you. Hopefully I didn't drag on too long.
Couple